Welcome to this module on radiological anatomy of the abdomen and pelvis. This module will cover normal and abnormal radiological images related to the abdomen and pelvis. Let us begin by looking at this plain film of the abdomen. This is an AP view or antero-posterior view of the abdomen. As mentioned in previous modules, one goes through a sequence of steps in order to interpret an X-ray. In this particular instance, we first make an assessment of the view. In this case, it is an antero-posterior view. Next, we make an assessment of the position of the patient. This is an upright X-ray of the abdomen. We then begin our clinical interpretation by first looking at the bony structure, then the soft tissues, and finally the pattern of gas distribution. The bony structures visible in this X-ray include the vertebral column, consisting of the lumbar vertebrae here, the 11th and 12th ribs on both sides, the sacrum, seen here with its associated sacroiliac joints, and then the pelvic bone. It is striking that the soft tissues are not clearly visible. This is due to the fact that most soft tissues have about the same level of radiolucency, and they are difficult to distinguish from one another. There are few structures that are landmarks in the soft tissue area, such as this particular line running obliquely across the right and left sides of the abdomen. These two lines are cast by the psoas fascia lying over the psoas muscle. Gas is visible in the abdomen, in the intestine here, and in the stomach and colon at other sites. Here we have an X-ray of the pelvis. This is an antero-posterior or AP view. The different components of the pelvic bones are clearly visible here, starting with the iliac crest, the iliac bone, the sacroiliac joint on the right side, articulating with the sacrum, the sacroiliac joint on the left side, the iliac crest and iliac bone on the left side, the hip joint with the acetabulum and the femoral head, the pubic ramus, the ischial tuberosity, the pubic symphysis, and the same structures on the right side. The subpubic angle in this instance is greater than 90 degrees, and this corresponds to the pelvis of a female. Since plain X-rays of the abdomen and or pelvis do not depict soft tissues clearly, a number of contrast-enhanced X-rays have been devised. This is an example of a barium meal. A fixed amount of a barium meal is ingested by the patient, and as this passes through the gastrointestinal tract, several images are created by taking X-rays in a timed sequential manner. In this example of a barium meal, one can see the stomach, clearly filled with the contrast material, the duodenum, and the jejunum. Another example of barium meal is shown here on the left side, which also shows the stomach and its subcomponents, the pylorus and the duodenum and jejunum. Note the variation in size, shape, and structures of the stomach. It is worth noting they are both normal, and this corresponds to the anatomical variation that exists between normal individuals. Here we have our first clinical case, a 35-year-old female patient who had recurrent bouts of burning epigastric pain which was related to eating. A barium meal was done, which is depicted here, and this corresponds to a close-up view of the pyloric part of the stomach, which is shown here, extending into the first part of the duodenum. And one sees here some dye material that is visible outside the normal lining of the stomach and duodenum. This is because a small amount of the dye has gone and filled an ulcer in the epithelium of the stomach and duodenum. This is a benign gastric ulcer. More commonly, an upper GI endoscopy is now used to visualize this pathology. The typical images that are produced as a result of endoscopy procedure are like this, seen here with the arrow pointing to the area of the ulcer. The big advantage of an endoscopic procedure is direct visualization and the ability to treat it in the same sitting. Another type of contrast X-ray that can be done for the gastrointestinal tract is a barium enema. In this particular instance, barium contrast material is introduced through the rectum to fill the large intestine. This example here shows the different parts of the ascending, transverse, and descending colon along with the rectum. Here is the cecum, the ascending colon, the hepatic flexure, the transverse colon, the splenic flexure, the descending colon, and the rectum. Note the pattern of the hostrations seen in the colon. Another example of barium enema is shown here on the left. Note again the anatomical variation in size, shape, and structure of the organs. They are both normal, and this only underscores anatomical variations. Here we have a clinical case of a 68-year-old male who complained of recurrent bouts of abdominal pain and diarrhea. The barium enema picture is shown here. This is a double contrast barium enema, so in addition to the barium enema contrast material, some air is also introduced into the large bowel. One sees the different parts of the ascending colon, the transverse colon, and descending colon. The striking difference from the normal barium enema is the loss or absence of hostrations. This is a typical picture of ulcerative colitis. Another type of contrast investigation that can be done is an intravenous pyelogram. In this particular investigation, a small amount of dye material is injected intravenously into the patient's circulation. The dye is filtered through the kidneys and collects in the pelvic-callaceal system of the kidneys and outlines the ureters and urinary bladders. Here we see the pelvic-callaceal system of the left kidney. Here it is for the right side. The ureter is delineated here on the right side and here on the left side, and this is the urinary bladder filled with dye material. Any structural damage or changes in the urinary tract can be visualized by this method. Here we have a clinical case of a 38-year-old male who complained of history of severe left flank pain radiating to the groin and hematuria. Hematuria is the presence of blood in the urine. The plain X-ray of this patient is seen on the left side here, and an intravenous pyelogram is seen on the right side. The left side here shows a radio-opaque shadow corresponding to the position of the left ureter, which should lie somewhere here. Because this is a plain film, the ureter is not visible. In the intravenous pyelogram seen here on the right side, one sees the pelvic calyceal system of the right kidney and the ureter outlined, and the bladder. The left ureter is not visible, but the pelvic calyceal system is seen here on the right side, which is dilated and enlarged as compared to the right side. This is a case of left ureteric calculus, and this stone is present right here in the left ureter. Multiple stones are also seen in the pelvic calyceal system of the left kidney. When one of these stones comes into the ureter, it creates the symptoms of pain and leads to hematuria. Another type of contrast film is a cholangiogram, which is done to highlight the gallbladder and the bile ducts. Here we see an example where a catheter has been introduced into the common bile duct and a small amount of dye is injected. This highlights the hepatic ducts, the cystic duct coming from the gallbladder, and the common bile duct. The dye material escapes out of the common bile duct into the second part of the duodenum. More commonly, gallstones are visualized using ultrasonography. Here we have a clinical case of a 42-year-old female patient who had a history of severe pain in the right shoulder accompanied with nausea and vomiting. An ultrasound done in this patient showed the gallbladder and a single large stone. This is an example from another patient who had multiple stones in the gallbladder as seen on ultrasonography. Another type of imaging which is contrast enhanced is an angiogram. In this example, a small amount of dye is injected in the arteries. The example shown here has a catheter placed through a peripheral artery, most commonly the femoral artery in the groin, up the aorta, and a dye is injected into the celiac artery. This delineates the branches of the celiac artery, including the common hepatic artery, the splenic artery, and the left gastric artery. An angiogram may be used to delineate more extensive branches of the aorta, such as the one shown here on the right side, where the common iliac arteries on both sides and their branches are seen, along with the descending aorta, the renal arteries, and several other branches. Here we have a clinical case of a 32-year-old male with a history of hypertension and evidence of bruit in the right flank. Bruit is the sound heard on auscultation using a stethoscope, which indicates turbulence in the flow of any fluid, in this case blood. The X-rays from this patient are shown here. The left X-ray is a plain film of the abdomen, which doesn't show any remarkable clinical changes. The right film is that of an angiogram. This is the aorta, the left renal artery. The right renal artery is extremely small, and this is a stenosis of the right renal artery. We have another case here of a 48-year-old male with a history of intermittent epigastric pain, usually relieved by antacids. And the patient now complains of a sudden onset of severe pain for the last few hours. The X-ray of this patient is shown here. It is interesting to note that this is neither an X-ray of the chest nor an X-ray of the abdomen. This type of X-ray is done when one suspects a perforated ulcer, in this case a perforated duodenal ulcer, and one can note air under the diaphragm, free air under the diaphragm. This is the right dome of the diaphragm, and this is the shadow by the liver. Here is the left dome of the diaphragm, and here is the upper end of the stomach. This air is in the fundus of the stomach, but this air here is free gas in the peritoneal cavity. Another example of this type of free air in the peritoneal cavity seen here in a child in a lateral position. The X-ray is taken in a lateral position and there is free air collected underneath the right side of the patient, and this is the air fluid level. Let us now look at a few examples of sliced data sets from CT scans. We will start from the superior end about the level of the liver and progress inferiorly. In this particular example, we see several structures of note. The right and left lobes of the liver are seen here. The stomach with the greater curvature and the lesser curvature are seen here. The spleen is seen on the left side. The aorta surrounded by the two cruci of the diaphragm, and the vertebral column and the cut sections of the various ribs. Note always, this is the posterior end, this is the anterior end, this is the right side of the patient, and this is the left side of the patient. All CT scan slices use this conventional method to display images. The next image is at a level slightly lower or inferior to the previous one. Here also we have a number of structures of note. The liver has become much smaller as compared to the previous slice, as it is more inferior. We see the gallbladder along with the cystic duct and the common bile duct. We see parts of the bowel, the transverse colon at this level, the descending colon on the other side. We see parts of the duodenum here and the pancreas. We again see the aorta and the two cruci of the diaphragm, and the inferior vena cava exists right here. We note the spleen on the left side. Note interestingly that the gallbladder has a radio-opaque shadow. This most likely corresponds to a gallstone. This is, however, uncommon because most gallstones are not radio-opaque but radiolucent. Thus, the best investigation to pick up gallstones is ultrasonography. Going a level lower, we see in this particular sliced data of the CT scan a number of important structures. The liver has almost disappeared. The two kidneys, the right side and the left side kidneys, are now visible. We do find the aorta sitting in the center, along with the inferior vena cava to the right side of it. There are various branches of the artery, such as the superior mesenteric artery visible here, the renal vein running across, and the head of the pancreas is seen sitting right here. Note the calcifications that are seen in the walls of the aorta. These are most probably calcified atherosclerotic plaques. Going a level below or inferior to the previous section, we have this CT scan which shows some important structures as well. The muscular wall of the abdomen, consisting of the external oblique, the internal oblique, and the transversus abdominis muscles are seen clearly on the right and on the left side. We find portions of the descending colon and other parts of the bowel, and we find the psoas muscle sitting on either side of the vertebra. Going further inferior, we find a number of important structures here. The bifurcation of the aorta, which is at the L4 level, the inferior cava, which is still one structure, and the ascending and descending colon. Going a little bit more inferior, we find the bifurcation of the inferior vena cava into the two common iliac veins. The two common iliac arteries are seen here. Okay, here's the pop quiz. A 28-year-old female had an X-ray of the abdomen. No other history available. Diagnosis, please. What do you see? This is a case of full-term pregnancy. If you note carefully, you see the head of the fetus here and the vertebral column of this fetus running down this way. This is a rare example because normally patients who are in full-term pregnancy will not have an X-ray of the abdomen. Another type of contrast study is a hysterosalpingogram. In this particular type of study, a small amount of contrast material is introduced through the cervix to outline the uterus and the fallopian tubes. Here we see the uterus, the right oviduct or fallopian tube, and the left oviduct, and some amount of contrast material has spilled out into the peritoneum. This is normal and indicates that the oviduct or fallopian tubes are patent. Here we have a clinical case of a 29-year-old female patient who was undergoing investigation for history of infertility. The hysterosalpingogram image is shown here, and this is a close-up view of the area of the film that depicts the uterus. Note that the normal shape of the uterus is distorted by this structure, which is a septa of the uterus. There is also a large swelling or lesion in this area. Such type of lesions can be studied with other investigations also, such as an ultrasonography, as seen here in these examples. Let us look at a few examples of fractures of the pelvic bones. This is a fracture of the pelvis at two sites, in the superior pubic ramus and the inferior pubic ramus. Since the inlet, the true inlet of the pelvis outlined here, is broken only at one site at the superior pubic ramus, these are categorized as stable pelvic fractures. A second example of a pelvic fracture is seen here, which is more severe than the previous one, and in addition to the superior and inferior pubic rami that are fractured, there is a fracture occurring through the right sacroiliac joint. And the right side of the pelvis is sheared and is higher up as compared to the left side. These are unstable pelvic fractures. Here's another example of a severe unstable pelvic fracture where the pubic symphysis has separated. CT reconstructions of pelvic fractures are helpful in studying the complex anatomy. Such types of pelvic fractures need open reduction and internal fixation with plates and screws, such as seen here. These screws fix the sacroiliac joint, and this plate and screws fix the superior pubic ramus and the pubic symphysis. Thank you very much. This brings us to the end of this module on radiological anatomy of the abdomen and pelvis.